Dextromethorphan, because even if it is considered as an antitussive, what we need to know is that it is not just an antitussive. It has multiple effects. It blocks the NMDA receptors, since it can produce hallucinations, euphoria, agitations, and all. It also binds the serotonin receptor, so patient can have serotonin syndrome in higher doses, especially if the child is on other drugs which will inhibit the MAO. Patient have seizures, muscle rigidity. Then it also blocks the reuptake of peripheral adrenergic neurotransmitters, which can lead on to hypertension, tachycardia, mydriasis, and diaphoresis. And it also binds the sigma opioid receptors, through which it has the antitussive action. So since it has all these effects, the safety of this drug in children below 4 years is not established. So it is not recommended for children less than 4 years.
See, the thing is that dextromethorphan, the main problem is lot of side effects are there, but it's very important to give the correct dose. The dose of the drug should be very correct. Up to 6 months, the maximum dose is 30. 6 months to 12 months, it is 60. Above that, it is 120 milligrams. So you must give the correct dose. If the dose exceeds the pharmacological dose, they can have lot of problems. Next question. Yes, Cam. Are cough syrups needed for children less than 2 years? We were all talking, and the government of India has put an order saying that cough syrups should not be given for children less than 2 years. What is your opinion?
Yes, sir. This is another
You support or not
another
support?
controversial question. So we have to discuss it in terms of the efficacy, the safety, and pharmacology of this thing. So from time immemorial, conventionally, most of the majority of us will be maybe using some drug other than paracetamol for even a common cold. But as per the available evidence, there is no proven benefit over placebo. Any cough syrup is not having any proven benefit over placebo in the RCTs. There is one Cochrane database of systematic reviews, which was published in 2014, which definitely proved this statement. And coming to the safety also, that is also a very important thing. There is a high risk of toxicity, like sedation, arrhythmias, convulsions, especially with the multi-ingredient syrups. And another important point is that most of the ingredients, including the expectorants or decongestants or antihistamines, they are lacking the pediatric dosing data below 2 years. So even antihistamines, as Sukumaran sir rightly mentioned, less than 2 years as of now, we do not have any antihistamine which can be used in that age group. So the regulatory alerts in the Western population, the US FDA and the UK MHRA, they contraindicate the use in less than 2 years, and the over-the-counter medications, they are discouraging the use in less than 6 years. So as of now, the government also have come with a directive that we should not use prescribe a cough syrup in this age group. So personally, I feel that is a right decision and we are supposed to follow that.
So, thank you, Krishna Mohan. Now to all panelists, what is your opinion about the government order saying that cough syrups should not be given for children less than 2 months? Jijo, please give your comments.
Considering the number of irrational medicines which is available in the market, and the parents can go and ask a pharmacist, what should I give my child for cough today? And the pharmacist can issue it, and the parent can just buy it and or repeat the same prescription which a pediatrician has given for another indication. Over there, in that scenario, it is always safer to say not to give. That will be one. But in specific conditions, if the child has seen a pediatrician and the doctor's prescription is very clearly and everything else is there from a hospital from such a similar setup, I would say in very specific conditions you can consider, but always only monotherapy and not a combination, and always for an extremely short duration with counseling for all the other possible complications to the parent.
Bindusha, what is your opinion?
Sir, I would also like to agree with Dr. Jijo. As a rule, for upper respiratory infection, we need not prescribe any cough syrup. But for specific conditions, like since this should not be a blanket statement as it, but for a specific condition like an allergic rhinitis or something, we should be actually able to prescribe a specific drug for that condition, even though some people consider them all as cough syrups.
And also those children present with wheezing. Wheezing is very common in children with an episodic viral wheeze, virus-induced wheeze. You have to give a bronchodilator. The drug of choice will be
We have to give.
bronchodilator. Immediately
Yeah.
after giving bronchodilator, the cough subsides. So such drugs can be given, definitely given. Even though you can call it as a cough syrup or not, I don't know. Okay. And next question, please. Yes, Jijo. What is the IAP guidelines on cough syrup in children?
So the IAP
IAP.
guidelines is very similar to what we have been talking so far, wherein it also recommends that under efficacy of cough syrups is in generalized, if you're generalizing, it is very minimal, or based on all the data, it is no better than a placebo for an acute cough, which is why none of the guidelines or none of the textbooks will have any recommendation for any of the cough syrups which are widely available. And use in children under 2 years is not recommended. Opioid antitussives, especially codeine, we have to be very careful and it's not recommended. Nowadays, it's not easily available also. Alternative options, primarily supportive care. Honey can be tried. We'll come to honey in the coming slides. But majorly against fixed drug combos, and parental advice becomes very important because at the end of your OPD, after seeing everything, the first question the parent is going to come, chomic endo kodukkunnu. Chomic marunilla. So the important point is to make them understand the cost of the cough, the course of the illness, and when they should be coming back to us with all the red flag signs, which is particular to the particular illness.
Okay, so very good guideline. Thank you. Next slide, please. Bindusha, what is the role of bronchodilators? We are talking about children presenting with cough. I think the commonest cause of cough in a child is again an asthma or this is an airway disease. They present with a recurrent episodes of severe persistent cough around early morning hours. What is the role of bronchodilators there?
Bronchodilators can be given if the child is having bronchospasm. Any child who is having bronchospasm, as Sir said, asthma is the most common cause for children coming to us with cough. Other than the upper respiratory infection, asthma is the one that we usually see. In those conditions, and also when the child is coming to us with viral induced wheezing, bronchopneumonia with wheeze, where all there is an element of bronchospasm. In those conditions, we can give them bronchodilators. But in the case of asthma and all, where you have inhaler drugs, we prefer to give inhaler than the oral medicine. But if it is just a pneumonia with wheeze, where you are not expecting the child to come to us again with wheeze and all, we may even be able to give oral bronchodilators also.
Bindusha, one more question. There are a lot of bronchodilators. You can have salbutamol, levosalbutamol, terbutaline. Which will you prefer?
Salbutamol is the one that we usually give. Why? Because
Yeah.
it is widely available and that has the clinical efficacy also. Levosalbutamol is actually less efficacious than salbutamol, even though the tachycardic response is less. The efficacy is also lesser.
See,
And
levosalbutamol, we are giving half the dose.
half the dose
Side
only.
effects is less,
Yeah.
but the effect is also half.
Effect is also less.
Jito, what is your opinion regarding? See, you are saying that it should not be given for children less than 6 years. Levosalbutamol is not very effective in children less than 6 years.
6
What is
years.
your opinion, Jijo?
Sir, if you look at the FDA guidance, what they have told is above 4 years is what levosalbutamol has been recommended, even as an MDI, and as a nebulization solution also, it will be above 6 years is what the data is. Wherein before that, there is no strong indication to use levosalbutamol. And in fact, like Sir has earlier told also in asthma and any of your GINA guidelines, there is nowhere levosalbutamol will replace salbutamol in either status asthmaticus or any condition. So given that the first line of choice will always be salbutamol and levosalbutamol, you will use it very sparingly, even though levosalbutamol is more easily available in the market and it's actually much more expensive than your plain salbutamol also.
What about terbutaline? Terbutaline syrups are available, lot of.
You can use it, sir, but I don't have much experience personally using it. So whatever I have had experience, it has been with just regular salbutamol, and the effect is what you expect is you can get it. But like is always told, it is not what will be your core treatment for asthma. It will always be your inhaled medications. This is only for a short term, or maybe for an intermittent visa, where the parents are not very willing and they want to attempt an oral medication.
So I think that the preferred drug should be either salbutamol or terbutaline rather than levosalbutamol. Levosalbutamol is
Yes.
not very effective. Not very effective.
Salbutamol is costly also. The cost
Yeah.
also is almost double.
Costly
double the
also.
cost.
See, one terbutaline syrup costs more than 100 rupees, 120. Terbutaline syrup, 120 rupees. But Astanin costs only 20 rupees. Such price difference is there.
Actually, when
Yes.
the salbutamol came under the price control, almost all the companies actually shifted to either levosalbutamol or terbutaline so that they
Ah.
could charge more. That is
Ah,
also.
that is why a lot of liver salbutamol preparation is available in the market now. Next slide, please. What is the role of mucolytics? Most of the cough syrups contains mucolytics. Will you do this or not?
Yeah, so mucolytics is also another drug which is most often misused or irrationally prescribed, especially in the less than 2 years of age. So we have the ambroxol, bromhexine, acetylcysteine, and carbocysteine. These are the major mucolytics we have. But if we check the limit, the age limit which is recommended, the lower age limit, it is recommended only from the 2 years and above in all these 4 mucolytics. And the basic mechanism of action is that it makes the phlegm thinner and less sticky. And there is another entity which is described, which is called as paradoxical congestion. That is especially in the less than 2-year-old kids, if you use a mucolytic, there is a chance that the mucus may become thinny and less sticky, and there is a chance of aspiration. So that is what is called the paradoxical congestion. So majority of the international guidelines are against using mucolytics in less than 2 years. So, but unfortunately in India, we have formulations including plain ambroxol, which is supposed to be used in less than 2 years. There are ambroxol drops also, but scientifically, if you are thinking, it is not supposed to be used. So basically, mucolytics are meant for chronic lung conditions like bronchiectasis and cystic fibrosis, not for a simple upper respiratory infection, or in our day-to-day practice, we are not supposed to use that.
Thank you, Shamavan. The most important point is it should not be given for children less than 2 years. Not below 2 years. What? We are giving mucolytics even for the newborn. Mucolytic drops are available. It is being lavishly given for newborn also. So the younger stage is 2 years. So for all drugs, not only for mucolytics, all antihistamines, all bronchodilators, you must know the younger stage at which you can prescribe these drugs. That is very important. Thank you. Yes. Bindusha, next slide. What about the levodopa? This is a very complicated name.
Yes, sir.
Levofloxacin.
So, yes, we took this drug because this was asked in one of the forums as to what is the current evidence regarding this. Before we come back, even oral salbutamol, the clearance is only for children about 2 years to use it at a dose of 0.1 ml per kg 8th hourly. That is something what the recommendation is. And up to 6 years, you are not supposed to exceed more than 4 milligram 8th hourly when you're using salbutamol. So that is roughly 10 ml 3 times a day is your upper limit for salbutamol, which you can give safely. But there are many people who actually use salbutamol in smaller children also. The risk for the oral medications is the adverse effect possibility is always higher. But salbutamol as a medicine, as a molecule, is something which all of us use, even smaller children as nebulizers or as inhalers. For example, if you have an asthmatic child who's coming at 1.5 years, multiple viral episodes, all those ages we have been using it. So in that aspect, this is something which you can consider. Coming to this drug, the next slide, this is not something which I've used, but I've been going through the evidence and this is what we could find. This is a newer drug which has been there, which is it's not a new drug, but it has been available recently in the market, which is a peripherally acting antitussive drug. It has been shown to have statistical significance, not necessarily a clinical significance, but statistical significance in efficacy in reducing cough frequency, severity, nocturnal awakenings when compared to central antitussives like codeine and dextromethorphan. So we have enough data to show in upper respiratory tract infection and bronchitis, in general, better overall antitussive effect and benefit risk profile when compared to the other medicine. Now, it is effective as before with it has a lower incidence of daytime somnolence, better tolerability. Majority of adverse effects are generally mild, making it a safe option in cough management. But we will come to the next slide as to what the further details are. The other drug, levofloxacin penzidioiode, it doesn't have enough data at this point to be recommended for children, not enough data to talk about what are the possible side effects also. Coming to the next slide, it's a single slide. At this point, it is approved for children about 2 years of age, generally contraindicated or not recommended under 2 because of sufficient data, sufficient safety data possibility, and potential risk is also always there. Dosage is going to be 1 mg per kg per dose, max 3 times a day, with a maximum of 3 mg per kg. Duration to be limited up to 7 days. Do not give it beyond 7 days. Age group is 2 to 14 years. Available strength is 30 milligram in 5 ml. But again, it has to be cautioned, especially if you're using in children who have hepatic or renal impairment. This is what the current status is about this drug.
See, Joe, thank you. But I want to confirm one thing about salbutamol. Salbutamol, we previously thought that it was not effective in infancy. But it is found that the bronchial smooth muscles are well developed even up to after 28 months of intrauterine life. Full time babies have got a smooth muscles are well done. I think so. Salbutamol may be effective in younger age children also. May be effective.
So the salbutamol as a molecule is definitely is going to act in smaller children also, but because the chances of a toxicity or adverse events will be higher when you're using an oral medication versus it in a nebulized form or as a MDA form. That's all.
Next question, please. Next question. Vidusha, you can talk about glycerol in cough syrup. This is a common component in cough syrup.
Glycerol is a common component in many of the cough syrup. It was actually originally used as the diluent in the cough syrup, but it does have different actions. Glycerol has lubricating action, so that it will actually prevent this irritation in the throat, especially when the tongue and the pharynx are moving. And it has demulcent action, which so that it has a soothing effect on the irritated pharynx. Then, due to the sweetness itself, it has a sweet, warm taste that also will decrease the coughing reflex. And also, it has humectant action where it will retain the moisture in the throat and all. So, due to these multiple actions, the glycerol itself will have some effect on the cough. It is said that around 85% of the effect in the cough syrups is actually due to the glycerol itself and not due to the active content in the cough syrups.
Next question. Oh, regarding honey in cough. Dr. Juja was also talking about honey previously. Bindusha, what is the role of honey? Can we give honey?
Honey
And
is
what is the
also
dose?
a demulcent. Honey is also a demulcent, so it has an effect on the cough. Especially, it also will have a soothing effect on the pharynx, and it will relieve some of the, especially the dry irritant cough, may be relieved by the honey. There are different studies, especially Cochrane reviews are there, which has reviewed 2 RCTs, which was done on 265 patients, and they actually compare different arms of the study where actually patients who were on no treatment at all, patients on honey and patients on antihistamines and dextromethorphan. What they found was that honey was better than either placebo or no treatment and also diphenhydramine, and the effect is actually similar to the dextromethorphan. So honey is something that we can use for the viral upper respiratory infection which is leading on to the cough. But it has some safety issues, especially in infants, because it may be contaminated with Clostridium botulinum and can lead on to botulism. So it is advisable that we use only pasteurized honey so that this contamination can be avoided. And honey is recommended also only in children above at least 1 year, maybe around after 2 years we can safely give honey. It is recommended at a dose of 2.5 ml, maybe at bedtime or 1 or 2 times a day, may be given to relieve the irritant cough.
Thank you, Bindusha. Even WHO recommends honey
yes.
as a home remedy
Yes.
in children, and that about 2 years. 2.5 ml in children about 2 years. That's right. KM, what is the timing of cough for etiological diagnosis that we usually see?
Yeah. So the time when the cough occurs most. Next slide, madam. Okay.
You are not well audible, Krishna.
Not audible, sir. Now.
Better.
Okay. So the timing of the cough is very important. It will give us a clue regarding what is the etiology of the cough. For example, in an asthma, it is mostly nocturnal. And if it is a postnasal drip, a cough which starts immediately after lying down or when the patient goes into the supine, it is a pointed towards a postnasal drip. And asthma, as I already told, it can occur also in the early hours of the morning. And when it is occurring after feeds in the lying down position, it is can be a clue towards an underlying GERD. And a cough which is getting worse in the evening, especially in the evening after the exposure to the irritants and the pollution, it can be due to some hyperreactive airway disease. And it can also be due to asthma. If it is an exercise-induced asthma, it can occur soon after exercise. And another important entity is the habitual cough or the psychogenic cough, which is typically absent during sleep. So that is also very common nowadays, especially in the adolescent patients. So that also we have to keep in mind.
See, one more point I want to highlight is again that if a child is presented with a persistent cough around 2 a.m., 3 a.m., 4 a.m., if you give a salbutamol MDI, salbutamol syrup, the child responds, it is definitely asthma. Then other problem is a child who's gone coughing during that time, while awake and disappears during sleep. Definitely it is an psychogenic cough. Next slide. Jito, what is the difference between viruses and cough duration? Viral infection cough duration.
Yes, sir. Before I just answer this, I'll just add a few points to the honey which we already discussed. Now, the problem with honey is majority of the recent study which they have done, they've shown us majority of the honey which is available in the market doesn't actually have honey in it. It is a sugar syrup which is available. Now, even the sugar syrup might or might not help a child. So I won't be surprised in the coming months we will have a pharmaceutical company which is going to come out with WHO approved honey, which is in a smaller bottle, which is pasteurized to be used only for cough. So that is going to be something which we have to see. But so many times when we say it is honey, it need not be honey what is actually available in the market. Now coming to the viral causes, it is very important to understand what virus is circulating in a particular season because as per the virus, the cough also might change. For example, if it's a rhino or a coronavirus, the cough. So instead of just saying it is a viral cough, if you are understanding what is the etiology and what is happening around you, you'll be able to counsel the child better. Because for a coronavirus or a rhinovirus in children, it was going to last around a minimum of 5 days up to 2 weeks. Majority get better by the end of 2 weeks. 50% of children stop by around 10 days. 90% will stop by up to 3 weeks. And around 10% beyond 3 weeks also it can extend, but rarely complications are seen and they resolve naturally. Irrespective, you give any syrup, cough syrups at this any point, it is going to take its own course to get relieved completely. If you have an RSV, the usual train which is happening right now, majority of the viruses which we are isolating at this point is RSV. So we have a minor RSV epidemic going across the state. So it will last between 1 to 2 weeks with infants and high-risk children having longer symptoms up to 4 weeks. So in infants, smaller babies, the RSV can be very detrimental. It will take quite a long time, including IP admission, a very long time for the cough to completely get better. Pertussis, like we all know, is a 100-day cough. So once pertussis starts, you will need your central antitussives to give some relief to the child as the child tides over the duration. But because of vaccinated, it is coming down. But at this point, we tend to see it in adolescents and bigger children. Now, viral infection, classically, your influenza, parainfluenza, adenometapneumo might take up to 3 weeks, but all these ones has a higher risk of having a secondary bacterial infection. Now, any point if the cough goes beyond 3 to 4 weeks, you have to make sure it is not a bacterial bronchitis, pertussis, or other underlying causes which is causing the cough to go on. Over to you, sir.
Riaz, how much time you can take now? Riaz is there. How much time? You have
Hello,
completed?
sir, it's almost 9:15.
Yeah.
Can we finish in 10 more minutes?
Okay.
Yeah,
I think
it will
there
be
are
over, sir.
a
It will
lot
be
of
over in 10
questions in the
minutes. It will
chat.
be over.
Krishna Mohan and all, there are a lot of questions in the chat box. I think we have to take it up. Next slide. Next question. This is regulatory and manufacturing standards. Why gaps occur in India and not in other countries? How to rectify them?
Okay, so next slide, please. So we have the regulations available in our country, but there are definitely some major gaps. That is why complications like these are occurring. And we will be discussing what are the regulations, what are the gaps, and how to fix them. So basically, this is regulated under the Drugs and Cosmetic Act, which is what is called as the Schedule M for GMP. GMP means good manufacturing practices compliance. That is what is required. So this is surveillance is done by the CDSCO, the central authority, as well as with the state drug controllers. But definitely there are some major gaps that may be due to some inconsistent surveillance. So maybe due to some poor raw material, maybe due to adulteration, all these things may be resulting. But the basic thing to be done for the fixing these things is that the law should be more strict. There should be strict enforcement of the revised Schedule M. And if anybody is not working as per this rule, they should be their license should be cancelled. But as doctors, the only thing that we can do is just to follow the available guidelines. That is, we have to stop all the irrational prescriptions. As Dr. Jejo mentioned in the beginning, we are having a lot of irrational combinations. So our duty and our responsibility as doctors is to follow the guidelines and stop prescribing any of the irrational combinations. That is it, sir.
Next question. Bindusha. What is the expert opinion regarding what happens in Madhya Pradesh and other places? Jijo, what is your opinion?
Sir, we spoke about it earlier. It is still the same point. It is first and foremost. It is, as we all know from all the previous experiences. I don't think it is the molecule which has caused. It is most likely the contaminant which has caused. Because when we look at dextromethorphan, the side effects doesn't have the classical presentation which the children presented, and further the death happened. It's very unfortunate that the doctor got arrested for something which is absolutely not in his control, which is contamination which is happening at the company level. And as we all know, even today there was an attack on a doctor which was there for a patient whom he has not even seen. So it becomes very unfair upon a doctor and everyone who's practicing when such things happen. And the law of the land, neither the people of the land stays with the person who's treating the patient with absolutely no bad intentions at all, sir. So the law has to be much more stringent in punishing the people who are actually responsible. And like rightly said, the one good thing which has come out is from this is no child, hopefully in Kerala, will get any medicines over the counter without a doctor's prescription. And as long as the pediatrician is seeing the child regularly, we will be able to prevent and cure most of the illnesses which come in.
I think we will wind up and we will take up questions from the chat box. Before that, I just want to ask
Yes,
the
sir,
panelists one question.
Sir, I would like our incoming president Nandakumar sir to chair the discussion session. He is also the president of the respiratory chapter. Over to
Okay,
Nandakumar.
Nandakumar, please come. And you can take up questions. And one more question I will ask the panelists. One point we had not discussed is almost all guidelines. They say that steam inhalation is found to be effective for cough. What is your opinion? Steam inhalation and cough.
Sir, the data has been very mixed, sir. So in children, majority of the whatever more than the benefit, all of us have seen cases of scald burnings coming in with children who have been taking steam inhalation. So that is the biggest risk. So more than the minimal benefit, the chances of a scald injury is very high. So a normal saline in itself will clear most of the secretion and work as good as a steam inhalation is what I believe, sir.
See, Jijo, what I want to say is that there's a very good article in one of the PCNAs which came earlier. They say that steam inhalation is not going to be effective. The only thing that, as you said, is it can produce scalds, and this is not beneficial. But some of the guidelines say that steam inhalation is found to be effective in treatment of cough.
The ENT people prefer steam inhalation for most of the causes, and they tend to write
but
it
we have
much
seen a
more
lot of
often
children
than
coming back with scalds.
Yes, sir. Yes, sir.
Burns.
Yes, sir.
Okay. Can you take up the
So,
Bindusha?
yeah.
Oh, Nandu.
Sir, thank you, Sukumana sir, and Dr. Bindusha, KM, and Dr. Jijo for that excellent discussion on these current issues which almost all doctors, are, especially pediatricians, are facing in our day-to-day practice. Because nowadays, if you write a cough syrup or if you write a bronchodilator, immediately the patient will ask, Doctor, kodukkan padundo. And otherwise, they will ask to medical shop. So, chomera merunnu venda, baki kodukko. So, I really like what Krishna Mohan concluded, because be rational. That is the one thing we can do. Be know about what you are writing. That is one of the most important. For which condition you are writing that, prescribing that drug, and you have to be very clear. And you have to be you should able to explain to the bystanders why I am writing this drug and what are the contents, what are the side effects of this drug. And as far as possible, use standard companies. That is another thing we have to do, because we have a lot of, as you all know here, we are getting a lot of pressure from pharmaceutical companies about writings of their products. So you decide which is standard drug and prescribe. So since time is running out, we are running out of
Bindusha,
time.
can you take up
I
the
am going to.
questions
There
in
are a
the
lot
chat
of
box?
questions.
Questions. We'll take up.
Nice.
I think a majority of questions Dr. Jijo answered in the chat box itself.
Yeah.
Somebody has asked regarding role of a Budicort nebulization in cough and age cutoff.
Say, questions are the role of Budicort in the treatment of cough. I think the only thing is that Budicort is a very good drug for treatment of acute asthma, persistent asthma. So those children presented with cough as a manifestation of asthma, they'll be beneficial. They'll be benefited. Okay, next question.
Sir, there is another question. What can we give for infant with bronchiolitis for cough?
Many questions on bronchiolitis. It will be better, sir. We can just
Yeah.
conclude it together about
Any other
bronchiolitis.
questions? See, regarding
Hypertonic for
bronchiolitis,
bronchiolitis, a
I
lot of
think,
questions are there.
see, regarding treatment of bronchiolitis, because there are a lot of controversies are there for treatment of bronchiolitis. Everything is controversial, except, as you know, oxygenation, maintain the oxygen by 95%. IV fluids, oral fluids can be given. What I want to say is that even some of the books say that you can have a trial of bronchodilator. Especially those children with a family history of asthma or atopy or personal history of atopy with first episode of bronchiolitis, they may respond to salbutamol. The cough may subside with salbutamol. I think the saline nebulization is found to be effective. Hypertonic saline may be effective. You can try hypertonic saline. And also it is very important that you wait for 1 to 2 weeks time. The cough will subside only within 1 to 2 weeks. Whatever drug you give, it will take 1 to 2 weeks.
So what about giving this saline nebulization, nebulization home?
Oh, see, I think even the main problem with saline is when saline can also produce bronchospasm. Saline can produce bronchospasm. See, for demonstrating mycobacterium, you can induce sputum. In the national guidelines, they say that you must give a salbutamol nebulization before giving hypertonic saline nebulization for sputum induction. So it can also produce problems. So I think nebulization should not be given at home. It should be oxygen driven, even this saline. Questions?
Then
I think most of these questions Jijo has answered in the chat box.
Yeah.
No, another question which they asked me is what about second generation antihistamines? Because you already mentioned that first generations and can induce convulsion.
Oh.
Yeah.
So what about because any antihistamines action central action, no doubt, they has got action. So it's a stimulant or it's because it can induce seizure. A child already on seizure or child on febrile seizure.
What I say is that those children who gives a history of seizure or who are giving anticonvulsants, anti-epileptic drugs, definitely you should not give any of the antihistamines.
Because nowadays.
And among first and second generation, the seizures are less with second generation. It's relatively safe. But it is better to avoid all antihistamines in children with a history of seizure or a child taking anticonvulsants.
Okay.
There are multiple questions about home nebulizations.
Yeah.
That is also some.
Yes, Krishna Mohan, you can talk on home nebulization. He's the ideal person.
Nebulization we recently discussed in Pedalarcon also last week. So home nebulization is not at all recommended. Even IAP NRC as well as Central IAP is strongly against home nebulization. So what is recommended is that only if it is done in a hospital with an oxygen, it is recommended. But nowadays, some of the parents last week they told they brought oxygen cylinder at home and they started nebulizing. So because they love the ambience created by the nebulization, the sound, smoke, etc. But we should not encourage using home nebulization because, as we know, the basic physiology, there is a chance of ventilation perfusion mismatch if you do it. So if it is done at home, there is a chance of some adverse effects occurring. So it should not be encouraged.
And also, MDI is equally effective as as nebulization
Yeah.
for treatment of mild moderate exacerbation. So you start with MDI, salbutamol MDI. Children up to 6 months, 6 years, you can give 6 puffs, and above 6 years, you can give up to 12 puffs. This is equally effective. Then ventilation infusion mismatch is less with MDI. Then why you go for nebulization? But people like nebulization. I don't know.
I think the discussion is
Yes.
going away from the cough. Now we are
Yeah.
discussing about the asthma. So we want to reach a conclusion and everything here because asthma is a very long subject and there are controversies there. So what we have to reach in a conclusion, that is I think more important than going on discussion on nebulization and some things. It will come and there will be so many
These are the questions asked by the
No,
audience.
because such a
We have to
question is
answer.
not, and because here we have to get a guidelines because DM is there, DH is here, everybody is here for getting a conclusion for cough syrup and cough remedies. I think
So
that
after this discussion, now I invite Dr. Riaz to give the final opinion and recommendation by Indian Academy of Pediatrics on cough syrups and management of cough. Dr. Riaz, please.
Thank you, sir, and the co-panelists for clearing most of the doubts. And I think now the group has a clear-cut idea of what to give. So one point which has been made clear is we can treat cough in children with the appropriate medicines when indicated. And remember, acute cough most of the time disappears without any treatment. And we should not go for any irrational combinations, FDCs, and we should all make sure our practice has to improve. And also another point is we have to ask the government to make the regulations very strict so that such mishaps should not happen in the future. I request the same group to give a written document also, which we can submit to the government as a part of our activity. Thank you once again.
So I think we can conclude. Yes, we can conclude now. I think the decision taken by the national body is a correct decision. No cough syrups in children less than 2 years. That's the best decision. Then cough should be treated as a symptom. As a symptom, you should not treat. You must try to find out the etiology of cough and use specific drug for treatment of cough in children. And also regarding antihistamines also, you should not use multiple antihistamines. Ideally, you should use only single drug as far as possible. Thank you.
Thank you, sir. Thank you, everyone.
Okay, we'll wind up. Thank you very much.
Thank you. Thank you.
Okay.
Thank you. Good night.
Bye.
Thank you. Thank you. Good night.
Thank you.